Hello, kidney warriors. James here with Dadvice TV, your online kidney health coach, and this is the latest episode of Dadvice TV Live. For those of you that are new to Dadvice TV, go ahead and hit that subscribe button. We talk about how to live better and live longer and manage kidney disease, and everything we talk about comes from either doctors, renal dietitians, other professionals in the kidney industry. You're not going to find any of those fake cures or any of those scams, and there's a bunch of them out there you got to watch out for. None of those here. Just real stuff that you can take, start acting on, and hopefully improving your quality of life and your life expectancy. Now tonight, we've got one of your guys' favorite regulars here. He is the author of a book that when I was diagnosed with stage 5 kidney failure, I wish my doctors would have handed me this book because it was scary. I left the ICU and had no clue what to do. I was afraid of what to eat, afraid of salt. I was completely lost and worried. But once I got a copy of this book and read it, I was like, holy cow, here's what I need to focus on. Here's what I need to do. Here's the things that are really important for me to pay attention to. And that book is Learn the Facts About Kidney Disease. This is the book for kidney patients. You can get it at Amazon. You can order it at any of your local mom and pop bookstores. Please give them some love and visit them. I was just at one on Sunday here locally, and I bought a few things, and so did my kids, and they really appreciate that. Amazon's got enough money. They're building spaceships and stuff. So let's go to our mom and pops. But anyway, the author, of course, right down there on the screen is Dr. Stephen Rosansky. So let's give him a great big giant welcome. Hey, Doc, how you doing today?
I'm great. Always love being on your show. It's one of the high points of my month. This is always fun. And I'm lately exploring the issue of how to not just live longer, but to live better. It's something called your health span as opposed to your lifespan. And we're going to have a few shows discussing ways to do that because unfortunately CKD is one of the things that will decrease both your lifespan potentially and your health span. So I'm going to tell folks things that may help you to improve both of those. And I guess you want me to introduce my background, James?
Yeah, because there's all those scammers out there, and let's make sure that our viewers understand you are someone important. You know what you're talking about. This is not one of those scam shows.
So I am a retired kidney specialist. I have taken care of patients with kidney disease for over 40 years. I still do it. I go to the free clinic once a month. As a matter of fact, I go there tomorrow. And I wrote the book that James told you about, Learn the Facts About Kidney Disease, because I realized that my colleagues across the world, especially in the developed world, are putting people on dialysis way too early at very high levels of kidney function. And my research, which was voted by my colleagues as my paper in 2011, which said that starting dialysis early may be harmful, actually, was voted the #1 game changer in my field. And I also have done a lot of work on the issue of what affects progression of kidney disease, what things make it worse, and what things can make it better to slow it down. And I also have had an appointment, I'm retired now, in something called epidemiology, and some of the stuff that I talk about is based on my background in epidemiology, which is basically population studies. And tonight we're going to talk about something that James loves to pronounce. And he's got a new way of pronouncing it. It's called Atherosclerosis.
Yes, right before the call, I told Dr. Rosansky, I was like, Doc, I've been practicing. I wrote down how to say it, and I said it wrong. But here we go. I'm going to say it correct now. It is atherosclerosis. Did I get it, Doc?
Pretty close, pretty close, pretty close. Yeah, it's unfortunately not a laughing matter. It's also called hardening of the arteries. Why? Because athero is paste and sclerosis is hard. And I don't know if any of you have had the opportunity to see what the inside of the major blood vessels look like. It's called the aorta. I've seen many of them. Even in young people, they've already got this yellow pasty stuff in there. And this stuff, this atherosclerosis starts in childhood. And why do we talk about it? Well, it's important for anyone who wants to live longer. And by the way, I'm on this longevity or health span thing kick, and I'm doing a lot of research in that area. So just as an important little tidbit, if you are 50, and James is around that, I guess.
I'm slightly above that. I'm
Yeah,
close. I'm
right.
50
Okay.
adjacent.
And you don't follow any of the lifestyle issues, you will live 10 to 15 years less. I mean, this is serious. 10 to 15 years less than people who follow all of these things that we talk about. So these are important. These are real things. This is not woo-woo. This is not take your supplement. This is not do some kind of cleanse. These are real things. And, the main deal for anyone who wants to do something good for themselves in terms of their lifespan and their health span is to keep your hardening of the arteries from getting worse. You don't reverse it. Nobody, no matter what anybody says, you're not going to clean your arteries out by some magic. You want to slow it down. You don't want it to get any worse. And what happens is that this cholesterol gunks up the blood vessels, and then your blood cells go in there, they eat the cholesterol, and then they form these plaques on your arteries, this kind of yellowish, gunky stuff. And then if you get enough of this stuff, it can clog your artery. You can get a heart attack, you can get a stroke, you can lose limbs from it, you can have no blood going to your legs and stuff like that. And then you can also have little things that flip off these plaques, little tiny pieces of blood clot that can go into your heart or your brain. So, and this is what will lead to getting a heart attack, a stroke, and amputations. Today, we're going to focus on one of the most important factors in kidney disease progression and atherosclerosis progression. It's your blood pressure, the simple blood pressure deal. The next talk, and I told James, I've already scheduled my next talk with James, is going to be about getting your bad cholesterol down, your LDL. And I think in the next talk, I'm also going to talk to you folks about should you take an aspirin or not, and is that one glass of red wine really making sense? So that's for our next talk. But today we're going to focus on blood pressure as our main topic. And by the way, those of you, just as a little teaser, you may have heard about bad cholesterol called the LDL, and you probably don't know what the new goal is. Do you know what it is? What should be? It used
Is
to
it
be less
60?
than 100. Well, it's actually 55. It used to be just less than 100. They keep moving the goalpost, and we're going to talk about ways to get it down. Today, focus on blood pressure. I want all of you to try to get to goal blood pressure. What is your goal? To get your top number to be about 120 to 130. And this is something you've all heard over and over again. Blood pressure is a silent killer. Why is that important? Because you got to check it. Otherwise, you don't know what's going on. It's a very, very important factor in getting a heart attack, getting a stroke, getting kidney failure, and getting heart failure. Excuse me. And the big thing is that a small change can have an enormous effect. Enormous effect. Not like a lot of stuff that you folks may be seeing on the internet about some supplements or some woo-woo that you take or some nonsense program. Get your blood pressure to goal will have a real effect. Again, we'll go through the basics. We've heard this many times. Those of you who watch any of the shows that I talked about blood pressure, top number on your blood pressure is what, James?
Your systolic, right?
You got it. Bottom number on your blood pressure?
Diastolic. Or
Okay. No,
yeah.
you got it. What's the normal value?
120/80 or better, correct?
All right. That's the normal value. An elevated value in today's world is 120 to 129. That was not the way it was 5, 10, 20 years ago. Not at
I
all.
remember when
This is
140 was considered elevated.
Well, James, I remember, and I did it myself. If it was a person of my age, I'm 77, and if you got a 160 on your top number, we go, oh, that's the blood pressure normal for older. No, no. You want to get to a 120 to 130. That's the latest goal. So the goalpost is moved. So this so-called stage 1, I don't believe in staging it. It's too many stages of kidney disease. But stage 1 is your top number is 130 to 139, over 80 to 89. And stage 2 is over 140 over 90. So stage 2, which is considered worse than stage 1, is where we used to be as a starting point. But now that's called stage 2. And and this is because the latest really good blood pressure study, which is called the SPRINT. You could look it up. The SPRINT study, SPRINT. That's where we came out with the goal to, if you're over 130, to treat it. Now, should you not get treated? Should you just try to deal with, conservative? What are the conservative things that can help get your blood pressure down, James?
Exercise?
Yes, true.
Low sodium diet, or not a high sodium diet?
Yes.
Medication, of course. Well, that's not conservative.
Before medication.
Yeah.
Another big one is stress. Okay, stress. So you got stress. Okay. So so I am not necessarily a big advocate of saying let's wait to treat your blood pressure because in most cases, unless you're on unusual stress, sure, wait a while, check it again, wait a couple weeks or months, and if you can really change your diet from extremely high salt to low salt, yeah, maybe makes sense. But there's one big one that is big because not everybody. People that can afford it are on the weight loss drugs. And if you lose 20% of your weight, which is not uncommon, you will get normal blood pressure in many, many, many cases. But most of the time, if you're over 130, I wouldn't treat you as the first visit, but I would certainly not wait very long. I'd get you on treatment. So one of the things that we've talked about on our shows here is something called the effect size. It's like what's the bang for your buck? You get virtually no bang for your buck with these nonsense supplements. I can guarantee that. Nothing. Zero. None of this, cleansing and all these other nonsense things. Diet, you can get some bang for the buck. Like if you went from a meat-based diet to a plant-based diet. Excuse me. I'm sorry.
You need some water with you, Doc, like I always have with me.
Let me take a drink. Sorry.
Yeah, and while you're doing that, we did have a question. A lot of times you talk about older folks, but you never say what older is.
And that is a no-no. And it used to be called elderly, and that's also a no-no. We call them older adults. I think anytime you're getting to be over 60, anybody who's older is at least 10 years older. When you get over 70, 10 years older. So, pick your number. There is no hard and fast number. Let's go to the effect size. So you get a lot of bang for your buck if you can lower your blood pressure. For example, let's say you got a patient out there that's watching that there's just top number 145, and it's consistently in that range. If you get it down 10 points to 135, you can decrease your risk of having a stroke by about a third. This is big stuff. You can decrease your risk of having a heart attack by 20%. Again, it's big stuff. For every 5 points you drop your blood pressure, you could get a 10% reduction in heart attacks, strokes, and death from heart disease. A small change is a big effect. So it is very, very worth your while to monitor your blood pressure and get it to your goal. First of all, before you can get it to your goal, you need to know how to measure it. And unfortunately, and by the way, the reason why I make a big thing about measuring it, because the study that came out, the SPRINT study, and there's been numerous publications about that study, they had a very specific way to check your blood pressure. If you go into your doctor's office, you've been running around and you're nervous and you run it and they check it right away, it's worthless. You need to be sitting quietly. You need to have back support. You need to have your legs on the floor. The blood pressure cuff should wrap around your arm at least 1.25 to 1.5 times. If it's too small, you'll get a false high reading. You need to be resting for at least 5 minutes. No exercising before you start the readings. You need to take at least 2 readings 5 minutes apart. Okay. Now, all of you, every one of you, whether you got high blood pressure now or not, get yourself a inexpensive little automated blood pressure machine. These are so useful. I can't tell you how many times I use it on people with various things. They feel weaker, dizzy, stuff like that. Get a blood pressure machine. You'll know what's going on. They're very cheap. They take it automatically. They're so easy to use.
As a matter of fact, I have, since I used to travel a lot, I have one by Withings that's about this big, and it's wireless. There's no cables or anything. It wraps around your arm, hooks on, it's rechargeable. It lasts for months on a single charge, and it will sit there, pump it up, measure it for whenever I travel if I wanted to check my blood pressure.
Excellent, James. Excellent, James. What kind of problems do docs have trying to diagnose blood pressure? You all know about the white coat phenomenon. James, tell people what that is.
Yep, you get there at the doctor, they're wearing that white coat, you get a little nervous, your blood pressure's higher. And mine always is, even though I look forward to going to the doctor because I get to get labs and I want to get my labs. Because I learned the hard way, you can't just go to one of those lab places and say, hey, I want labs. You got to have your doctor ask for them. But even mine, I go to the doctor, it's always higher by a little bit. And I think part of it is I'm walking upstairs, I come in, and boom, that's first thing to do is blood pressure. They don't let me relax. At home, mine is well within normal.
And that's really the key message. Check your own blood pressure at home. Your doctor's office blood pressure is not magic. You can even get a lower blood pressure on rare occasions in the doctor's office. This is the reverse of white coat. So it's what you're getting when you're home and you're at work, if you're able to check your blood pressure, not every day, on occasion, just so you get an idea. What is my work blood pressure like? What's my blood pressure in the morning? What is it at night? Just get some information and give that to your doctor. Doctors love to get that data because the data point in an office visit is not really useful. What you can deliver to your doc as far as your blood pressures in various situations will be very, very, very useful. Okay. Now, what if your bottom number is high but your top number isn't? Let's say you got a 120/90. Do we treat it?
I'm going to guess no, because the bottom number, I believe, is not as critical.
The current thinking is different than what you said, James. You do want to treat the bottom number to get it to 80. You don't want to get it much lower than 80, maybe 75, 80, because once you start getting around 60, the thinking is you may not be getting enough good head of pressure to get blood flow to the arteries, tiny little arteries to your heart. So you do want to treat if you got a bottom number up above 90 and even though the top number is normal. Now, how often should you check blood pressure? Too many people obsess over it, and the more you obsess over it, the higher your blood pressure.
That used to be me. I used to check it every day, every morning and every evening. Now I just check it once every few weeks, just to see how I'm doing. And if I don't feel well, I would check it. And I know your recommendation is if it's time to take blood pressure medication, you feel a little dizzy, check it, make sure you're not too low, and then you're going to make it lower by taking your blood pressure medicine.
Perfect. You said that perfect, James. You got the message. I love it. This is very important. My wife just started on blood pressure medicine. And sure enough, she says, I'm dizzy. And she stood up and her blood pressure was 90. As I said, hold that medicine. Okay.
Yeah.
And so, especially if you're feeling weak and dizzy, and I can tell you in my practice, and I've seen a lot of inpatients that were sick people, but I can't tell you how many patients had looked too low. Their blood pressure was aggressively treated, and it was too low. So you don't want to overtreat, you don't want to undertreat, and if you're, as James said, if you are feeling funny, you want to check your blood pressure, and if it's, let's say, running in the 190, 100 range, hold that medicine. Wait till the next dose. It's not going to hurt you to wait a dose. Most blood pressure medicines say, don't stop this medicine. Wrong. I think it should say, feeling weak or dizzy, hold it. If it's too low, wait for the next dose, because you don't want to overtreat it. What are some of the things that can make blood pressure difficult to control? James, you know these, I would guess, right?
Difficult to control. Well, kidney disease, first of all, because your kidney disease controls your blood pressure, and by controlling your fluid level and your electrolytes. I'm not sure what else is the answers.
Okay. The number one thing is people get confused. And I'm here to tell you that you don't need to be confused. You don't need to be taking medicines more than twice a day, at most. Too many doctors are still prescribing the old medicines that are 3 times a day or 4 times a day. Nonsense, unnecessary. The maximum should be twice a day. And one of the reasons why people have lousy blood pressure is they're not taking it correctly, or they're not taking it at all. And there's other things that can do it, like you're taking a street drug, obviously that can raise your blood pressure. People sometimes are on, for attention deficit, Adderall, Ritalin, that can raise your blood pressure. And you may need more medicine in that case. One big thing is a lot of drinking can raise your blood pressure. Be careful. And alcohol may become just as nasty as we used to look at cigarettes. And we're going to talk about that maybe on our next show, about how alcohol is not a great thing for your health. And things like Motrin, we all take it. If you're taking a lot of Motrin, it can work against your blood pressure drugs. Then there's things that are kind of rare that you need. If your doc is not getting your blood pressure to your goal, it's time to say, hey, doc, should we get another opinion? Maybe get an expert. And generally speaking, kidney docs are some of the best to treat blood pressure. You may have one of these so-called secondary causes. Most blood pressure is essential, meaning we have no clue. It could be due to kidney disease, as James just said. Yeah, kidney disease can certainly raise your blood pressure. But you may actually have trouble with your arteries to your kidneys. There's a lot of some so-called secondary types that you need an expert to help diagnosis. And you really should get it to your goal. And whether it's your blood pressure or your LDL, which we'll talk about next time, don't accept my blood pressure is 160. In today's world, you may need to get to an expert to figure out why it's remaining high. Assuming you're compliant, obviously, you got to be taking your medicines. Mm-hmm. When should you take your blood pressure medicine?
When should you take it? So I take mine in the morning when I get up, except for the ones that make me sleepy. I take those just before bed, and it knocks me out. About an hour later, I'm asleep, which helps me stay asleep throughout the night.
Yeah, I think it doesn't matter. I mean, it was at one point, there was a big push, and I used to go to the hypertension meetings one of my specialties has been high blood pressure. I've done, in addition to kidney research, I've done a lot of blood pressure research. I did a lot of research on what they call 24-hour blood pressure monitoring, where we put a monitor on you for 24 hours to see what your entire day looks like. But you can take it any time, but just take it at the same time. Keep on a schedule. And again, if you're feeling crappy, you're feeling dizzy, don't just take it. Check your blood pressure before you take it. You don't want to overdo it. And now, if you are over 160, and that's not unusual, you're going to need probably at least 3 drugs. And too many docs are a little timid in how they dose the drugs. And we've discussed on other shows about ways to slow decline of kidney function. If you've got protein in the urine, the first thing your doctor should be doing is to give you the maximum dose of a what or a what?
ACE or an ARB, which are
Yay,
very
James.
affordable and very common.
All right, James, you hit it on the head. And anyone with high blood pressure should have their urine checked for protein. There's a lot of undiagnosed kidney disease with people with high blood pressure. Everybody with high blood pressure at some point should have their kidney function checked and the urine protein checked. And, blood pressure control is one of the real important things, as everybody is worried about having progression of your kidney disease and having to go on dialysis. Getting your blood pressure to goal is one of the proven most important things for anyone, whether you got protein in the urine or not. Getting your blood pressure to goal is something you should all be shooting for to keep you from ever going on dialysis, because that's one of the things we have control over. And we'll just kind of touch on some of the meds, and I think we'll have time for some questions. Let me have another drink or something.
Yeah. Well,
Okay.
and the nice thing about, and this is kind of tapping back into some of the previous conversations, a nice side effect or benefit of these blood pressure medications is that they've been shown to be helpful in eliminating or reducing protein in the urine, slowing the progression of kidney disease. So it's not just getting your blood pressure under control. There's other benefits for kidney patients.
Right. For anybody. I mean, again, it's going to decrease your risk of heart attacks, decrease your risk of strokes, and decrease your risk of heart failure. Our last show was about the connection between kidneys and heart. Heart failure is extremely common for anyone with kidney disease, especially for older folks that have stage 4 CKD with GFRs of 15 to 30. Very common to have heart failure. So first choice drugs are your ACEs and your ARBs. And James has listed them probably at least a dozen times on my show, and he will list them again. And I will let James tell you how to know if you're on one. How do you know if you're on an ACE?
Okay, I don't remember which one's which. One is Prill and one ends in tan.
Right. If you're on an ACE, it ends the name of the compound, the generic name, ends in Prill, like captopril, enalapril, lisinopril, lisinopril. Okay. And the ARBs end in tan. Losartan, candesartan, olmesartan. Okay. The tans are the ARBs. So this is something that I probably haven't mentioned in the prior talks. Generally speaking, the ACEs may be a little bit more valuable, although they're interchangeable, because there's an enormous number of studies on patients with heart failure, on patients with kidney disease, on diabetics with the ACE. And so in general, you might want to start on an ACE. They're probably equally good, but who should definitely be on an ARB, Jane? You know about these.
Yeah, is that the one where you get the cough? If the cough from the other one?
Right. If you get a cough, that's from one of the prills, the ACEs, right? that or swelling of the lips, this is unusual, and it's an absolute indication to go on a TAN drug, an ARB. Okay. The other very, very common drugs that are used, and a lot of you folks are probably on it, is the calcium channel blocker. Have you heard that term, James?
Yep.
And there's a real common one. Do you happen to know what one of the most common drugs prescribed? Originally
Is
made by
that one the
Pfizer.
spirolactone?
No, that's
Or
the
no?
aldosterone. We're not going to do that tonight.
There's so many of them.
I know, James. I'll just take a pause here. But James, I think, has one of the unusual, and I think maybe a secondary type of blood pressure that is caused by having a too high a level of something called aldosterone. And those of you who have been on the shows that we talk about the drugs to slow progression, one of these blockers of aldosterone that James is on is called spironolactone.
Yeah.
That one can have a marked effect on your blood pressure if you're one of these folks, like James is what I think, that have high aldosterone levels. The calcium channel blocker that so many of you folks out there on is most popular one prescribed is amlodipine. Amlodipine, also called Norvasc. Very, very widely used drug, and I've got a lot of experience with it. The benefit of the calcium channel blockers is what? What are in addition to being pretty decent drugs to lower blood pressure? What's another benefit of the calcium channel blockers?
I cannot remember.
And the original one was Procardia. That ring a bell? Nifedipine. It was prescribed for people with chest pain. It was prescribed as an angina drug. But in today's world, it's used pretty much as a good baseline after ACEs or ARBs. I would think about amlodipine. Other calcium channel blockers that you may have heard of, may not. There's something called diltiazem and verapamil. Those are also calcium channel blockers. They have a special benefit in that they can slow the heart rate down. And they're sometimes used for people who have something like atrial fibrillation, a real common condition, and high blood pressure. These drugs not only can lower the blood pressure, but can also slow your heart rate down. It's called diltiazem and verapamil. What's something that most people with high blood pressure should be on in addition to the drugs I've already mentioned? What type of a drug?
Is that the GLP-1s?
No, you're in a different talk.
I've got all the different medications up, and I'm like, so that I can look up the names of all the drugs that fall into them.
Now, GLP-1s are the weight loss drugs, and they are the drugs that are currently probably also beneficial to slow progression. Now, I'm talking about a real simple, very basic drug that you're probably on. You are on it with the spironolactone. It's in combination with some other type of drug called a
SGLT2?
no. A diuretic, James. A diuretic.
Oh, a diuretic. That's
diuretic. Right. A diuretic. James, you just keep reminding me of just how slow I've got to go and how I've got to repeat my messages because it takes a while to get through. Thanks for reminding me, James. You are the average person listening here.
Exactly.
And you know, I've got to keep repeating it. So, water pill.
And I have so many pills that I take, but it works, so I'm good.
But I would advise all of you to please bring your medicines that you're taking to the clinic. I can't tell you how many times the list of medicines that I think a patient's on have nothing to do with what they've got at home because they're getting medicines from 5 different doctors in 5 different places. Please bring your medicines to your appointments with your provider. HCTZ, you heard of that? HCTZ, hydrochlorothiazide.
Oh yeah, yeah. I think that's one of the ones I take.
There you go. It's a very low dose water pill that sometimes you can have it in combination with an ACE or an ARB. I'm good with that. An ACE or an ARB with the water pill combined. It's a good way to deal with it. And then another water pill is called hygrotin or clothalidone. If you have more advanced, if you're like stage 4, if you're like in the 15 to 30 range, or you've got a lot of fluid. By the way, a lot of fluid can make your blood pressure harder to control. If you can take your finger and stick it, press it against your ankle, and you can leave an indentation, that's called edema. And if you've got a good bit of edema, you may need to put a stronger water pill. And a good name there is Lasix furosemide. You heard of that one, okay? And if you happen to be one of the many people who've already had a heart attack, you need to be on a drug called, you know this one? A beta blocker. If you had a heart attack, you need to be on a beta blocker at least for a year for protection against sudden death. The beta blockers are atenolol, metoprolol, propranolol, carvedilol. These are the beta blockers. And the drug that James just was referring to that helps them sleep is a really strong drug. It's a really strong drug. It's called what, James?
Clonidine.
Yes, you got it.
And I take 0.2 milligrams twice. And I just take them both at night. And it is a struggle to stay awake. You have to have like something going on where your adrenaline kicks in to fight off that sleepiness. But I love it. I take it at 8 o'clock. By 9 o'clock, I'm in bed. 9:10, I am sound asleep.
It's also called Catapress, and it comes in a patch as well. If you are having trouble taking pills, you can ask your doc to get this Catapress patch. It's clonidine in a patch form, and you change the patch every 3 days. It's a great way to do it, and that's another alternative. If you happen to be a man and you're having trouble getting the urine started, getting your stream started, your doctor may put you on something called an alpha blocker. Names here are terazosin and prazosin. They are also pretty good blood pressure drugs, and they may also help men with prostate problems. One word of caution there, your doctor will tell you, when you first start it, it could cause you to drop your blood pressure on standing. So that's the deal with those drugs. The most powerful drug, and I think in today's world, it is extremely rare for you to have blood pressure that can't be controlled. You need to get a blood pressure specialist like myself. I use the most powerful drug called minoxidil. It's the drug that if you rub it on your scalp can grow hair. And it's the drug that women with severe blood pressure, in my experience, would stop taking because of the hair growth. And unfortunately, some of them died from their high blood pressure. But it can get your blood pressure controlled. A drug that's sometimes still used, it's a 3 times a day drug. I don't recommend it. It's hydralazine. It's like minoxidil, but it's a weak sister. And if you're taking either minoxidil or hydralazine, you have to be for sure on a water pill, and those drugs can get your heart rate up. You probably need to be on those beta blockers, the things like propranolol, carvedilol, those kinds of things. So I'm leaving time for questions, a good bit of time.
Well, there are plenty of questions.
Next time, I'm going to get you folks to know how to get, this is as important, not quite as important, but in the same range in terms of the effect size of getting your bad cholesterol down to that goal. And the goal is really low now, it's 55. And we're going to talk about how you do that. We'll also talk about should you take the baby aspirin, and we'll talk about should you have that one drink a day. And in future talks, we're going to talk about things to affect your lifespan. We'll have a whole show on exercise. We're going to have a show on keeping your brain healthy. And we'll have a show on what are the warning signs of a brain attack. It's a new way to call a stroke. It's a brain attack. People know about heart attacks and what you got to do if you think you're having a heart attack. I'm going to take you down the road of knowing what you need to do for yourself or someone else if they're having a brain attack, which can keep you from getting a paralytic stroke. And we'll also talk a little bit at some point about some people say, well, you know, I got heart disease, you know, I got bad genes. Guess what? That's not going to determine what's going to happen to you. Your genes are not your life, what's going to happen to you. It's only maybe 10 or 20% of what may happen to a person is what's passed on. A lot of it is what you do, your lifestyle factors, which we started the show and say you can add 10 or 15 years to your life if you follow these lifestyle factors and these drugs like blood pressure and cholesterol drugs. So, James, I'll let you start out by giving me some questions.
All right, one question has popped up quite often about taking your blood pressure is the wrist blood pressure monitors. Are those accurate? Are you okay with them using those? I always do the ones at the upper arm, like your doctor does, but what do you think of the wrist ones?
Here's what I would do. I would buy, you know, a standard, you know, pharmacy blood pressure machine, and you can get the one that James said. You can get any machine you want, but what you need to do, bring it to your doctor's office. Check your blood pressure from your machine against what they're getting, so you know you're in the same ballpark. And as long as your machine is going to give you consistent results, and you're using that data for yourself and for your doctor, you're fine. Any machine is fine.
Perfect. All right. Frankie, who I think is a new viewer to this episode, is 70 years old. He's a male. His GFR is 36. He wants to know your thoughts. Is that bad? Not bad?
Okay, so not a question of bad or good, Frankie. It's a question of where you've come from and where you're going. And one thing that we've talked about on many of the shows is that one data point is meaningless. And one of my competitors, whatever you want to call it, selling books about kidney disease, this is not a kidney doc, pushing very low protein diets, talking about nonsense about people's kidney number going from, let's say, 36 back to 60, right? And this has nothing to do, I can promise you, with being on a very low protein diet. There is no good evidence that very low protein really makes a difference, other than it can make you malnourished and lead to bad things like breaking bones and so forth. But you want to know what your pattern of kidney number is over time. And it can vary a lot from one office visit to the next. So just don't panic on it. If you are one of the people that have protein in the urine, for sure, go over some of the talks that we discuss, the drugs that can help slow decline of blood pressure beyond the blood pressure medicines. These are the drugs that James mentioned, GLP-1s and SGLT2s, but we're not talking about that tonight. I'm gonna take one here from Michael. GFR rising slowly, move from stage 5 to stage 4. Well, look, this answers the question you just got from someone else. You can be moving back. There is no such thing as being in stage 5, being in stage 4. It's just a way for us kidney docs, especially us research kidney docs, to categorize people. They really have no meaning. It's not all of a sudden you're in a much worse shape going from your number that's theoretically in a stage 5, stage 4. It's the combination of your GFR, your kidney number, and your urine protein Those data points over time is what matters. That's really the thing that you need to focus on.
Can you talk a little bit more about how your EGFR does fluctuate? There's a lot of questions about that.
There are things that are known to change your GFR. Most important and most common things, especially in the severe heat that we're having around the world, dehydration. You get dehydrated if you've already got a GFR, let's say 40 or so, it can easily drop to 20 with dehydration. It'll go back to 40 or 50 when you get hydrated. A lot of the drugs that people take, like Motrin, the NSAIDs, can have a big effect on dropping your kidney function. So, yeah, the big one, and if, like we talked about in today's talk, if you lower your blood pressure too much, that in itself can decrease your kidney function temporarily. It's called what, James? Our AKI.
AKI, acute
this,
kidney injury.
Yeah, it's these, and most of these cures that you're going to see advertised about someone going from a GFR of 15 to 60, they were AKI, and James is a walking, talking example of that. He himself had this severe stage 5 that was an AKI. Most of the ones that you're reading about are AKIs. You don't get quick changes, certainly by any of these things like very low protein or supplements or anything like that.
And just to be clear with everyone, you can have CKD and get an AKI on top of that, plummeting your GFR.
Yep. Beverly's asking about cramps at night. I'm sorry to tell you, but we have not come up with anything really good for cramping at night. I don't have much to say. I mean, certainly it's possible that it could be an abnormal electrolyte problem, and getting your drug screen for electrolytes, including magnesium, calcium, and all the usual stuff, that's at least worth looking at. Dawn has stage 4, GFR 27%, 4.5 years. Okay, fistula. Okay, Dawn, my thing about whether it's time for getting a fistula, and again, please, Dawn, look at my book, look at the chapter about early start of dialysis, when it makes sense to start dialysis. Don't be one of these people that gets pushed onto dialysis when you don't need it. And when do you need to be thinking about getting the surgery to go on a kidney machine, which is called a fistula? It depends on your age. If you're an older person, you have stage 4, you likely will not need dialysis. You'll likely die of something else. If you're a young person, doing it earlier may make some sense. But in general, I think it's stage 5, less than 15, for most people when you start thinking about having the surgery to prepare you for the machine. And more importantly, and I'll give a plug for what James did. Was it last night or night before last?
Last night.
James is talking about trying to get people to volunteer to donate kidneys. And there's an exchange program, people waiting for a kidney. They can get somebody else who's got a kidney that doesn't match them that they can exchange to you. Or there are people that are strangers that are willing to donate kidneys. But in the U.S., once you have a GFR of 20 or less, get on the transplant list. So Dawn, get on the transplant list since you are, you're actually 27, you have a 27%, so it's a little bit high. Once you get below 20, I'd get on the transplant list. It's a little early to be talking about a fistula, and certainly way too early for dialysis.
And Dawn's a regular. I know she's going to tell her doc, not yet when it comes to dialysis until she's really low.
So here's someone, GFR readings 4 months, stage 4, 30. So and this is great. It's just, thank you, Raj. It shows you so well how these numbers just bounce around, and it doesn't mean a thing. your number, think about it, is at least up or down 10 or 20%. So if you're 4, it could be plus or minus 0.4, 3.6 to 4.4 creatinine, or GFR of 40 could be 44 or 36, same number, okay? And that's a very good example. Thank you for those data. Someone's on Cyprus, CKD is improved. So now this, good evening from Cyprus. So your GFR, okay, this is unusual. So once you're getting down to, like, I guess GFR 9, went to 16, and now I think my guess is it was that the 9 was a fluke, or when you get into GFRs of 30 or less, it takes very little dehydration, lower blood pressure to get your GFR to change a lot. And before I would let anybody put me on dialysis or put a fistula in, make sure that your level is remaining at a level that's appropriate for any of these things consistently. And but Cyprus person, you should be preparing yourself for the transplant or learning about dialysis. And my book talks about all of these things if you're interested. And somebody's plugging your living donor. You want to give me one, James?
Let's see. Let me switch over to a different screen here. Let's see. We talked about the leg cramps. Oh, there were a number of people asking about sleep issues. What are your recommendations for kidney patients that have issues sleeping? And when I was at my worst, I had problems sleeping at night.
Yeah, well, you're talking about something that I've had since I'm a kid. So I am a chronic insomniac, which, thank God, is a rare thing. And I've got 5 kids, and I thank God none of them have it. You know, there's a lot of stuff. I think the last thing you should do is take a sleeping pill. Absolutely the last thing. If you can deal with a catapress for your blood pressure, like James, that's not a bad thought to ask your doctor about that. I generally start out with, I mean, you know, there are people that like to take what is the diurnal drug that a lot of people take. I can't think of it offhand. But the thing that can help put you to sleep is something called Benadryl or diphenhydramine. It's an antihistamine, 25 milligrams to 50 milligrams, especially if you've got allergies, which most people do have. That could be a good thing to help with sleep. Get out. Don't get your screens away from you. No alcohol before bedtime. Close the shades. Make your room cool. That's a biggie. Keep your room as cool as you can afford to. Cooler room will help you fall asleep. No screens. Try to get the stress away before you go to bed. No alcohol. And, you know, if you're really having trouble, short-term use of the sleeping drugs is a last resort. I wouldn't go to that initially.
Valsa asks, how long does it typically take to get past an AKI?
Well, okay, so there's a lot of different kinds. There are some that you can have to be on dialysis for a short time. If you get your blood pressure low enough, your kidneys may go down in function where you require, I've seen people on dialysis for a couple of weeks and then they get better, which brings up another crucial point. If you have AKI, like James or like so many other people, and your doctor is talking about, hey, get you ready for dialysis, let's see if my kidneys are recovering. If you've had a drug that you were on that was messing up your kidneys, or you're dehydrated, or your blood pressure was too low, or you had a heart failure episode, wait, see if one of those things are corrected, your kidney function gets better before committing to a lifelong dialysis. And AKI could be corrected within days, or it could be sometimes, as I said, several weeks.
When does a doctor order a kidney biopsy?
Okay, kidney biopsies are generally done when you've got a question of a protein type of kidney disease, which is called glomerular, because there's two parts to the kidney. One is the glomerular, which is where you get the filtration, glomerular filtration. The other part is the tubules, okay? If your glomeruli are leaky, you could be leaking protein. That's when a lot of docs are going to want to know what type, and there's a long list of these glomerular diseases that you may have. They'll also want to do some blood work to see if you have various types of glomerular disease, including, you may have heard of lupus. There's a bunch of other names I'm not going to throw at you. But that's the time. Before I would agree to have my kidney biopsy, which is basically a simple procedure, I would ask your doc, is this something, the result of this biopsy, that is going to change how you're going to treat me? If the doc says, well, no, or I'm not sure, then say, well, then why are we doing it? You want to have a good reason to do a kidney biopsy. Shirley has a blood pressure of 80 over 50. Shirley, is that a consistent blood pressure? It may be due to a weak heart. If you've got very weak heart, congestive heart failure, there are people, and a lot of my patients with weak hearts walk around with an 80 or 90 top number. And it's too low is not a great thing. And there's probably a reason for it. And my guess is it might be due to heart failure. Let me see here. You got another one, James, you want to give me?
Let me see. I'm sitting here marking
let
some
me,
of them.
All right, let me do this one. Someone is on 10 milligrams of lisinopril. Look, should you be on a higher dose? I don't know why your doctors started. That's what I would call a homeopathic low dose, extremely low dose. And stage 3 for a lot of people is not really kidney disease. If you're in your 70s or 80s and you're above 45, you may not even have kidney disease. And if you don't have protein in the urine, I don't even know if you have stage 3. So it certainly is not enough if you got protein in the urine, 10 milligrams. You want to be on the maximum dose that you tolerate. And I don't know what your blood pressure level is. Sandy, let's see. You got one, James?
No, I just started typing Sandy to bring up
Okay.
the one you were about to say. And Sandy's one of our regulars. She's my buddy just across the border.
No, Sandy's, it's a great story, Sandy. 210 over 110, lost 130 pounds, and the blood pressure is that. I mean, and a lot of people, if you can afford these drugs for weight loss, you will get your blood pressure down if you lose a significant amount of weight. There's no question about that. Should I be doing this?
Yeah, we have time for maybe one more question.
Okay. Fluctuating GFR is very, very common. We've already talked about it. Somebody mentions, should you be worried about fluctuating GFR? I've got a lot of people that have GFRs over years I've followed, and they may be bouncing around with a wide range of between, let's say, 20 to 50. And they keep coming back. As long as your GFR comes back to a baseline that's higher, I wouldn't worry about it. There's a lot of things that your doctor should be looking for that are reversible causes of a lower GFR. Too many to get into because it's already time to the end.
Yep.
We're out of
We're
time.
at the top of our hour. We have so many people watching right now and so many comments. We really, really appreciate all of you out there. The more comments, thumbs up, that helps. get these videos recommended to other people on YouTube, which pushes the scammers and their fake cures and things that only drain your wallet and could even be harmful, pushes them lower on the recommendations. All right, so I'm going to mention your book one last time. So anyone who's new here, you saw what Dr. Rosansky's like. His book, Learn the Facts About Kidney Disease, makes understanding CKD, what you need to do, when to start dialysis so you don't accidentally allow a doctor to put you on it too early, and so much more, all covered in his book. It is super, super easy to read and understand. It's, it's not, you don't need a PhD to read it. I've bought so many kidney books that are difficult. I need a thesaurus to look up all these medical terms. You don't need it with this. So I, encourage everyone, go down to your local mom and pop store, show them some love, and order a copy. And it's very, very affordable. All right, Doc, you're going to be back on September 12th. So mark your calendars, everybody. I'll be posting it, which we're going to be talking about getting your bad cholesterol down, your LDL, and we're going to talk about the low dose aspirins, those 81 milligrams, which I take one. It's one of my big old list of pills every day. We're going to talk about all that. And I think this is the last video that I have scheduled for this month. Yeah, I think it is. I'm going to try to squeeze one more in with someone who is on dialysis to talk about her story and some of her challenges looking for a kidney donor. We'll see if we might be able to squeeze that one in this month. I want to thank everyone for being here. Thank you, Dr. Rowe. Always educational, always a pleasure. And I am so appreciative of the great comments like Don, who says, James, you are so funny. I am so real. I am just a regular person who has a gigantic list of medications, can't pronounce 90% of them, and I just do what my doctors and dietitians and stuff recommend, and it works for me. I avoid all those scams out there. And Dr. Rowe and I both get all these scam emails. We share them with each other like, hey, here's another scam. Listen to the professionals. All right, Doc. Thank you so much. And thank you, everyone out there. And I'll see you all in the next video. Bye, everyone.